All patients required chemoradiotherapy, so you had to need chemoradiotherapy to enroll in the trial, and you had to get bilateral neck radiotherapy. So the patients who were most at risk to have the highest toxicities. It was 70 gray, like most of you have experienced if you've been treated for definitive radiotherapy, delivered over 33 days. And it was just the difference of the technologies. And what we saw was, first and foremost, we wanted to make sure that we were not sacrificing cancer outcomes for these patients. So the NCI and NIH required that our primary endpoint had to be progression-free survival in what we call a non-inferiority design. So we had to enroll a lot more patients at 442 to prove that, because we're not just proving it's something better than something else. We don't expect it to be better in cure rates. Cure rates are great with IMRT. Instead, we wanted protons to reach that same level but reduce toxicity. So that required 440 patients to show, and in point of fact, it was a positive trial showing that, in fact, IMPT, intensity-modulated proton therapy, is non-inferior in cancer cure rates to IMRT. So we got the same cure rates, and that's what we expected. We also saw in the per-protocol analysis, not just the intention to treat, that was the case. However, this was something we did not quite expect. So overall survival in the intention to treat analysis showed a 10% survival difference at 5 years. Meaning if you were treated on the proton machine, in 5 years, you are 10% more likely to still be here. Why was that? If cancer outcomes weren't different, why are patients surviving better in one arm who just got a different technology? And I'll try to convince you in the following slides that it has to do with the side effects. The side effects of head and neck cancer chemoradiotherapy are very severe, whether it's dysphagia-related deaths or psychiatric-related deaths, or if it's malnutrition-related deaths or diminishment in our immune systems. All of those things significantly contributed to deaths in this trial. And in point of fact, I think one of the interesting points about this is whenever we see a difference like this that we didn't expect, people go, well, did one arm do worse than expected? And in point of fact, that yellow arm, which is the IMRT arm, which is the X-ray arm, did exactly the same as all of the randomized trials that we've had in the phase 3 fashion in the last 30 years for head and neck cancer. What to do for patients in this trial was give them a gastrostomy tube or a PEG tube before they started radiotherapy. We rarely use NG tubes, but more often use directly into the stomach tubes through which patients will pump in food for nutrition. Has long been standard in radiotherapy from the 70s, 80s, and 90s to always put these in. And in the 90s and 2000s, it started to become a patient-by-patient decision about what their nutrition level was, what their support level was, and whether or not we thought, as oncologists, we could get them through it without it, or whether or not that patient thought they could get through without it. So you can see that only about 5%, actually a little less than 5% of patients had a gastrostomy tube when they started chemoradiotherapy. And in the red arm, you see the X-ray patients. The first 90 days after therapy, there was about a 30% relative reduction in feeding tubes placed in patients who received IMPT versus IMRT. So significant reductions in how often you got a feeding tube if we tried not to give you one. So we tried not to give these patients one, they only got it if they needed it, and there was a significant reduction in the IMRT arm. There was also a significant reduction in patients who could not maintain their weight through therapy, and that's what you see in the bottom right if they received protons instead of photons. I think this is actually one of the more telling slides to me, and it's one of the less ballyhooed parts of this trial though. This is a publication we were allowed to put out a little bit before the trial was actually published, but it showed work productivity outcomes, and what I'll tell you is that there's going to be a publication, don't tell anybody, but it's going to keep going out to about 5 years, and it holds this number. So we asked patients at the beginning of therapy, are you working? Can you do your normal work? What is your business? What is your daily? And about 2/3 of patients, even before they started therapy, said, yeah, I can still do my normal work. And then we watch them during therapy and after therapy to kind of see not just what we see cancer outcomes, not just what we can measure as far as how we affect you with chemoradiotherapy, but how does this change your life? And how does this change your productivity and your contribution to society? And what we see is in the IMRT arm, we got 60% at the beginning about that are working. That drops to about less than half of patients who can work in any form throughout the course of therapy. Unfortunately, it stays low at 6 months, a year, and 2 years out from therapy. Only about half of patients are back to work after chemoradiotherapy with X-rays. Whereas the darker black line on top is the proton arm, where we see about 2/3 of patients can work at the beginning, but it rises to 70% and up to close to 80% by 2 years out from therapy. So not only are we affecting, things we can measure about their dry mouth or swallowing or their feeding tube placement rates, but they seem to be more productive and more normally functioning individuals, able to do what they want to do as far as being productive in the proton arm of this trial. And remember, again, it's just a different machine, different technology, same number of treatments, same experience largely for a patient as far as a mask and a table and so on and so forth.